Morning, everybody. It gives me great pleasure to welcome you today to our Healthier Together Lunch and Learn session on paediatric epilepsy. It's great to have so much interest in the session and to have so many people here, and I anticipate that the number will continue to climb as we go through. Usually these sessions are led by my colleague Laura Cassidy, who holds the reins on the Healthier Together Champions work, but she is unfortunately unavailable today. But we were really keen to be able to continue to deliver the session, so I'm hopeful that I'll be able to fill in and do today's session justice. So by way of introduction then, my name's Louise Dauncey and I'm a Network Delivery Manager for the Child's Health and Wellbeing Network. My main role and responsibilities relate to the delivery of the Children and Young Persons Transformation Programme here in the North East and North Cumbria. I'm joined today by my colleagues Sophie Gilmore-Ivans and Dr. Kumar, who have worked closely with me over the last 18 months on the Paediatric Epilepsy Service Improvement Programme and the implementation of the National Epilepsy Care Bundle. Sophie will be delivering the main part of the session, and I hope to just provide an introduction to the network to set the scene. And Dr. Kumar will be available in the chat throughout and obviously for the discussion and question session at the end. So this session is all about paediatric epilepsy, so we hope to provide colleagues and participants with an understanding and an awareness of the needs of somebody with epilepsy and provide some top tips and advice on how best to support them in the community. And we will be recording this session. So just to give a brief overview, outline of the session, I'll provide a bit of background and context around the network and a reminder about Healthier Together, and then I'll hand to Sophie, who'll cover the main session, and she'll touch upon the areas listed here, and we'll then have the opportunity for participants to ask Sophie and Dr. Kumar any questions. Next slide, please. So just to set the scene around the levels of challenge in our local geography, as a professional living and working in this area, I'm sure you'll be well aware of the challenges of deprivation and the impact of this on health and other outcomes for our children and young persons population. We know that we have a lot to do to improve outcomes for children and young people and their families living in poverty, who are even more challenged to support their own improved health and well-being. Part of the work that's been done around the Healthier Together programme is to support a reduction in A&E attendance because we have the highest rates of admission in the country for children under 5. For us then, this is about reducing those pressures and supporting the healthcare system, but also trying to support families to make informed choices and to help them navigate our complex healthcare system through the role of Healthier Together website and mobile app. The stats here on the slide give an overview and an understanding of the size of the challenge here for us in the North East and the issues that we're contending with within our health system. Next slide, please. So just to highlight the benefits of Healthier Together and the opportunity to support parents to understand what action is needed and to provide consistent information and advice. Can I just ask people to put their microphones on mute if they're not speaking? Thank you, that's great. So in terms of the known impact so far for Healthier Together, the website itself has over 245,000 users since going live. Over 7,500 children are now signed up to using the app. 2/3 of the children who have ended up in self-care disposition or ended up staying at home. We've upskilled the VCSE and education settings to signpost families to Healthier Together to access resources online, and we've supported schools to improve school attendance, and we've increased parental confidence with self-care and allowed them to provide the support that they need at home and be confident to do so. Next slide, please. So this is just an outline of the role of the North East North Cumbria Healthier Together Champions. Champions have been highlighted in areas of high emergency department attendance, and we've got more than 300 Healthier Together champions within the VCSE and education settings, which are working directly into underserved communities with the potential to reach into more than 70,000 families. Next slide, please. So from a network perspective then, the Child Health and Wellbeing Network was established in 2018. We have a shared vision that was brought together following consultation with professionals, agencies, parents and carers, and also young people. Our mission statement is outlined here on the left-hand side of the slide. We believe that children should be given opportunities to flourish and be advantaged by organisations working cohesively together. Our role as a network then is to provide the opportunities for connection through platforms such as this and working with partners to share good practice and drive improvement and programmes forward. The colourful wheel on the right-hand side of the slide displays the Child Health and Wellbeing Network's priorities. These are our shared priorities that have been determined by this initial consultation about the gaps and what the needs were, and what our work should focus on. Further consultation was undertaken after the first wave of COVID, and the priority about family support that you can see added here in blue on the wheel on the right has been added in response to the more recent feedback. These areas you'll see within the wheel, mental health, childhood illness, inequalities in access, etc., will be no surprise given what we know about the levels of relative deprivation in our area. Next slide, please. In terms of network delivery then and reach, we do a lot of work in our network around comms and engagement. You can see here that we've got a lot going on in relation to opportunities for engagement such as huddles, lunch and learns and other interactive learning sessions, social media interaction, as well as our weekly Child Health Tuesday newsletter bulletin. We have wide network membership. We currently stand at over 2,000 people. We have a youth board and a range of networks, a network of networks, that we connect into to support to facilitate youth voice and engagement. If you're not already a member of the network, I would really encourage you to sign up to be part of some of these opportunities. Next slide, please. So as a network, we have a sort of quite diverse and wide-ranging a set of delivery areas. So we have responsibility to deliver the Children and Young Persons Transformation Programme, which is largely my portfolio area of work, leading on the long-term conditions, transitions and other children and young person transformation deliverables. I work really closely with Laura Cassidy, who delivers the Integration Centre programme and includes a range of things, including the Healthier Together programme and other innovative initiatives. So this session today ties up these two aspects in relation to paediatric epilepsy as a long-term condition, and obviously the role of Healthier Together and the role of the Healthier Together champions. So we also deliver this work around tackling inequalities, and we have responsibility around the Core 20+5 programme. It forms part of our core business, and this work is led by Jen Hicken. We have a range of other work, and more information is available on our website, and the link is on the slide for you to be able to look at that at your leisure. So this is just a whistle-stop tour of the network and hopefully gives you a flavour of our role and remit. I'll hand to Sophie now, who will deliver a really informative session on paediatric epilepsy. Thanks. Over to you, Sophie.
Hello, my name's Sophie Gilmore-Ivans. I am a paediatric epilepsy nurse at Northumbria Healthcare, but I'm also currently seconded into role as the strategic nurse lead. Next slide, please. I'm actually going to turn my camera off because it'll help with streaming. So I'll start with a question for you. What is epilepsy or the epilepsies? So epilepsy is a tendency to have recurrent epileptic seizures more than 24 hours apart. It's a variable condition that affects different people in different ways, and approximately 1 in 200 school-aged children and young people in the UK have epilepsy. I've put the epilepsies in brackets because of the diversity of types and causes and the fact that we need to remember that it's not a single condition. Next slide, please. There are many causes of epilepsy, and I've put the most common causes up there. Anything that alters the structure of a child's brain can give rise to epilepsy. Now, this could be a tumour, although that is incredibly rare, or a child's brain may develop differently when they're in utero, or they could have had a stroke or a head injury that alters the structure of the brain and leads to them having epilepsy. We know that some epilepsies are caused by a mutation or change in a single gene, whereas other epilepsies are presumed to be caused by the combination of genes that a child has inherited. Any infection in the brain, whether it's bacterial, viral, fungal or parasitic, can cause epilepsy, and although not in the UK, worldwide infection is the leading cause of epilepsy because the developing world still has infections like TB and malaria which can affect the brain. There are neurodegenerative conditions in in childhood that have epilepsy as part of them, and for some children the cause of epilepsy remains unknown. Next slide, please. So another question for you. What is a seizure? It's a sudden and temporary increase of electrical activity within the neurons, which are your brain cells. Seizures can affect part of the brain, and we call these focal seizures, or the whole of the brain from the onset, and those are generalized seizures. What a seizure looks like depends on what area of the brain is involved, and lots of people are very surprised to hear that there are over 60 different types of seizures. Next slide, please. So this is a seizure map. And you can see that the brain on the left has a small purple area, which I've used to denote a focal seizure, which starts in one area of one lobe of the brain. Because each part of the brain is responsible for a different function, how the seizure presents itself will depend on which part of the brain it starts in. So, for example, the back of your head, the occipital lobe, the back of your brain is responsible for vision. Therefore, if you have a focal seizure in your occipital lobe, you may see flashing lights, colours, or simple patterns, or you could have temporary loss of vision. We try to say what we see with seizures. Therefore, focal seizures are either described as focal aware seizures, where there's no change in the person's awareness, or focal impaired awareness seizures, where, as the name suggests, there's a change in the person's level of awareness. So during a focal impaired awareness seizure, the child or young person might be able to hear you, but not fully understand what you're saying to them, and they may not be able to respond to you. And if they do respond, it may not be as they would normally. We also describe focal seizures as motor or non-motor seizures. And motor seizures, as the name suggests, are seizures involving movements, such as jerking or repeated movements. And focal non-motor seizures are when the main symptoms don't involve your muscles. They can include things like changes in emotion, thinking, and sensations. And examples of this would be experiencing déjà vu, getting an unusual smell or taste, a sudden intense feeling of fear or joy, a feeling of numbness or tingling. And as I've said before, what happens will depend upon which area of which lobe of the brain the seizure has occurred in. Underneath the focal seizures on the map, excuse me, you can see focal to bilateral tonic-clonic seizure. This is when a seizure starts in one area of the brain and then the electrical activity spreads to the rest of the brain rather than being confined to the area in which it started. And the young person goes from having a focal seizure into a tonic-clonic seizure. Tonic meaning stiffness and clonic meaning jerking. And that's the type of seizure that most people associate when they think of epilepsy. On the right of the seizure map are generalized seizures. This is when the whole or the majority of the brain is affected by the seizure from the start, and the child or young person will lose consciousness with these seizures, albeit only briefly for some of them. And again, we try to say what we see. So, atonic seizures are seizures without tone, and someone falls limply to the ground, almost like a puppet with the strings cut. Tonic seizures are stiff seizures, so you might fall, but there won't be any jerking movements. Myoclonic seizures. Myo means muscle and clonic means jerking. So these are seizures involving muscle jerks. They can affect a single hand or foot, or the head or half of the body, or sometimes they affect the whole body and the child or young person will fall to the floor suddenly. Absent seizures are the most common seizures that you see in primary age children, and approximately 10% of children and young people with epilepsy have absent seizures as part of their epilepsy. And there are typical and atypical absent seizures. In a typical absent seizure, it lasts 5 to 20 seconds. The child stops and stares into space. They don't respond to people around them. Their eyelids may flutter. They could have slight jerking movements of their body and or their limbs. There could be automatisms, which are repetitive, purposeless movements like lip smacking or plucking clothes. And typical absences can occur in clusters. An atypical absent seizure lasts longer, more like 20 to 30 seconds. They start and end more slowly, can involve a change of tone, and the child may be able to respond during the event, but this won't be a normal response. So one of the young people I look after who has atypical absent seizures, she stares, she looks blank, and then towards the end of the event, she'll say, "I'm sorry, I'm sorry, I'm sorry," just as she's coming out of it, but she has no recollection of the event and absolutely no recollection of having said, "I'm sorry," towards the end. Next slide, please. So I'm going to talk to you about seizure triggers, and these are things that can provoke seizures. This isn't an exhaustive list, but the ones we see most commonly, I think, in my practice are illness, with or without a temperature, and lack of sleep or disrupted sleep. In girls, menstruation can be a trigger, so even if their seizure control is good for the rest of the month, the hormonal changes associated with their period can trigger seizures, and this is usually in the 2 to 3 days before the period starts or in the first 2 to 3 days of menstruation itself. And sometimes girls and women can have seizures around the time that they ovulate, again because of hormonal changes. If a child or young person isn't taking their medication properly, this can cause seizures. Most anti-seizure medications are given twice a day, every day, as close to 12 hours apart as possible. And if children are missing doses or there's no routine to when they're being given, it increases the likelihood of them having seizures. And that's because what we want is for the level in their bloodstream to be consistent across a 24-hour period. And those medications that are given twice a day, every day, the way they're absorbed by the body means that that 12-hour gap then means that there is a consistent level in their bloodstream. But if somebody is being given their evening dose at 8 in the evening and then they're not getting their morning dose, say till midday the next day because they've slept in, then there's going to be a period of time between 8 o'clock in the morning and midday when they take medication where actually there's going to be a drop in the level in their bloodstream. And some children can get away with it, but lots of others, that's then a risk time for a seizure for them. I've put flashing lights and photosensitivity on the list, as there's a common misconception that everyone with epilepsy is photosensitive. However, realistically, it's around 3 to 4% of people with epilepsy, and I'm going to discuss this more on the next slide. So next slide, please. So photosensitivity. It's not just about flashing lights, and seizures could also be triggered by high contrasting patterns such as stripes or bars with contrasts of light and dark, and these patterns are more likely to be a trigger if they're changing direction or flashing, rather than if they are still or moving slowly in one direction. So things that have been reported to me as being triggers are sunlight through slatted blinds, or through the trees when you're driving down a tree-lined road, or sunlight reflecting off the waves at the beach, or light through a moving ceiling fan. Similarly, an animated background on a Zoom or Teams call, or a moving escalator can also trigger a seizure, and it could be any type of seizure, but tonic-clonic seizures are the most common. If you're working with a young person who you know is photosensitive and you want to try and minimize the risk of a seizure, you can make sure that a room is well lit if they're using a screen so that there's less contrast between something like a computer or a TV screen and the rest of the room. You could use an anti-glare filter on a laptop or a desktop. And if the child or young person says that they're feeling odd or they don't just seem right, get them to cover one eye with the palm of their hand, move them away from the possible trigger and remove them, from the area, because that might give you enough time to get them away before the seizure starts. But please don't ask them to close both eyes, as this could cause a flicker effect and make the situation worse. Next slide, please. I'm also going to chat about conditions that mimic epileptic seizures, because there are quite a few, and we need to make sure that we get this right for children and young people. Daydreaming or inattention can be mistaken for absent seizures, and a child who is having actual epileptic absent seizures can be mistaken for regularly daydreaming or being inattentive before they're diagnosed. Young people with diabetes whose blood sugar falls, or any child with a very low blood sugar, can have a seizure as a result of it. Dissociative seizures are events involving uncontrolled movements, sensational behaviour that are not caused by the abnormal electrical activity in the brain that causes epileptic seizures. To the untrained eye, they might look exactly like an epileptic seizure, but there are often subtle differences that allow those of us working in epilepsy services to tell the difference. Febrile seizures are seizures that occur when a child under the age of 6 has a temperature. And it's good to know that febrile seizures are 10 times more common than epilepsy. So in an under 6 who has a seizure with a temperature, the chances are it's much more likely to be a febrile seizure rather than an epileptic seizure. Although very occasionally, little ones who have a diagnosis of epilepsy or are waiting for a diagnosis of epilepsy will have a seizure with a temperature, and that has been an epileptic seizure that's been provoked by being unwell and having a temperature. But you need to allow us in our epilepsy teams to unpick that. Some of the symptoms of migraine, movement disorders, parasomnias, which are events that occur from sleep, tics or Tourette's syndrome, and panic attacks can be mistaken for focal seizures, and syncope, which is fainting, can be mistaken for a tonic-clonic seizure, as more than 75% of people who faint will have some brief jerking movements when they're on the floor. Next slide, please. So I'm going to talk a little bit about first aid for focal impaired awareness seizures. So if you remember from the seizure descriptions, these are seizures where the child or young person will have some alteration in their level of awareness during the seizure. But that level of awareness can be variable, and they could also continue to walk through the seizure. Therefore, it's important to keep them safe. They may need to be guided away from any obvious dangers like roads, water, sharp or hot objects, or stairs, and you should avoid doing anything that will frighten them. After the event, they may need a short period of time, maybe 10 to 20 minutes, to recover before they can return to an activity, and they may need reminding about any information they've missed during the seizure. Children or young people who are conscious during a focal seizure do not need to be placed in the recovery position. Lots of first aid training only covers tonic-clonic seizures, and therefore people who have had some first aid training often think that the advice for all seizures is that someone needs to be put in the recovery position. Trying to move a child onto the floor who doesn't want to be moved could distress them, and you could also injure yourself or, hurt your back. I usually advise allowing the child to adopt whatever position they feel most comfortable in, which might be to stay sitting where they were, or they might want to move onto the floor, which is fine as long as they're safe. If a young person goes from having a focal seizure into a tonic-clonic seizure, which we talked about previously, a focal to bilateral tonic-clonic seizure, you would then follow the first aid advice for tonic-clonic seizures. And I've added a link to a video of a focal seizure from the Epilepsy Action website. So once you're given the slide deck after this presentation, you could watch this at your leisure. Next slide, please. So tonic-clonic seizures are the seizures where the child or young person is unconscious. They are initially stiff, and then they have rhythmical jerking movements. You should time it from the beginning and time the duration of the event. Move objects away from the child rather than moving them unless they're in immediate danger. And again, immediate danger would be something like in a road, in a pool, at the top of a flight of stairs, next to a Bunsen burner, something hot. You're going to cushion their head with something soft like a cushion, jumper or coat, but you're not going to make it so bulky that their head is forced onto their chest, because actually that's not a good position to breathe in. You can ask for another adult or first aider to come and help you if you need an extra pair of hands. And then once the jerking phase has stopped, you're going to gently put them into the recovery position, if you know how to do it, or onto their side if you can't remember how to do the recovery position. And this is to allow any accumulated saliva to run out of their mouth and to help aid their breathing. Please don't put anything in their mouth except for those children who are prescribed emergency medication, and certainly don't put your fingers into their mouth. There are some myths about tongue swallowing, and historically people have placed fingers or hard objects into people's mouths during a seizure. We don't do this, and the most likely outcome of putting your fingers into their mouth is that you'll get bitten. And because people's jaws can be very stiff during this type of seizure, if you do put your fingers in and the child or young person clamps down on your finger, you're not going to get them back until the end of the seizure. Again, I've added the link to the Epilepsy Action video, which shows first aid for a tonic-clonic seizure. And again, you can watch this at your leisure. Next slide, please. Epilepsy does have a lot of impacts on children and young people. So behaviour, some of the anti-seizure medications can cause mood and behaviour side effects. And sometimes families will tell me that their child has had a total personality change when we start some of these medications. And in the run-up to some seizures, families will report a change in behaviour in the child that seems to reset once the seizure has taken place. And I'm not completely sure why that is, but it's been reported to me enough times that I take it at face value. Learning. Some of the epilepsies affect children's abilities to retain new information or to understand certain types of information. Approximately 40% of children and young people with epilepsy also have a mental health disorder, and this is most likely to be anxiety and/or depression. In terms of school attendance, children and young people will need time off for their clinic appointments, where their epilepsy is reviewed by their consultant or their epilepsy nurse. Everyone is individual, but some children or young people may need time off following a seizure, especially if it occurs as they're waking up in the morning or results in an admission to hospital, or they're given emergency medication to stop the seizure, as this can make people very sleepy. Some of the anti-seizure medications can cause side effects like vomiting and diarrhea. And although these tend to be transient and more prevalent when we're first starting a medication and increasing the dose, most activities like brownies or swimming club and schools won't allow children to attend if they've got diarrhea and vomiting. Sleep. Some of the anti-seizure medications can make children more sleepy, especially when they're first started or when the dose is increased. And there is one anti-seizure medication that we use regularly that can cause insomnia in some children. If a child's had seizure activity overnight, even if that's not outwardly visible, if you've got seizure activity in your brain, that can disrupt sleep, but can then result in a child being sleepy in the morning, either because their sleep has been disrupted, or they might have had a tonic-clonic seizure during the night, which will make them tired. And I've put stigma and bullying because there is still a lot of misunderstanding about the epilepsies amongst other young people, which can result in children being bullied. Next slide, please. When I think about safety for children with epilepsy, I always think about what could pose a risk if the child has an impairment of their awareness or loses consciousness. Hot things like radiators, fires in forest school, or kettles, hobs and oven in food tech or in other cooking activities could cause burns or scalds if a child has a seizure next to one. Therefore, activities need to be risk assessed, and ideally the child should be paired with a friend so that they can still take part in the activity, but they don't do things like putting baking trays in and out of the oven, because even if they have an absent seizure for 5 seconds, they could sustain an injury. We don't recommend that children or young people with active epilepsy are at height without a harness. So tree climbing and ropes and bars, wall bars in schools are not safe, whereas activities like rock climbing and abseiling, where everyone is harnessed and there is the risk of falling for everyone, are actually safer. As long as the activity is being risk assessed and the person holding the safety rope knows that if there is a risk of seizures, as the young person has epilepsy, so they're kind of pre-warned. I usually find that when children go to outward bound activity centres, it won't be the first time they've worked with a young person with epilepsy, and the staff will already know how to adapt to the activity. But if you need any advice for that kind of activity, you can always contact your epilepsy specialist nurse in your local area. You have to be seizure-free for a year before you can drive a car. Therefore, we apply the same rules to other activities like go-karting and quad biking, as losing consciousness during both of these activities could result in serious injury. Cycling on off-road cycle paths and in parks is fine, but the young person shouldn't cycle on the road until they've been seizure-free for a year. And obviously also children should be wearing a cycle helmet to prevent a head injury. It's recommended that children and young people with epilepsy shower rather than bathe unless they have adult supervision, as an unsupervised seizure in a bath poses the risk of drowning. If the shower is over a bath, they shouldn't put the plug in, as this then poses the same risk as a bath. And ideally, the bathroom door should remain unlocked, so assistance could be provided in the event of a seizure. Young people with epilepsy can swim in pools, but they need appropriate supervision, which should be an adult, either in the pool or on the side of the pool, who has responsibility solely for that child. So, if it's a school situation, there isn't just one adult watching the whole class. There might be an additional adult, maybe a learning support assistant, who is watching the child with epilepsy. If the child has a seizure in the swimming pool, the adult should alert the lifeguard, and they may also need to enter the pool to support the child in the water with their head above the water until the seizure's ended, and then you can safely remove the child from the pool. Open water swimming and water sports should be avoided until the young person has been seizure-free for 1 year. Some surf companies who are able to provide a higher ratio of staff to children may be able to accommodate a young person with active epilepsy, but generally we discourage open water sports in children with active epilepsy until they've been seizure-free for a year, because actually getting someone safely to shore or back to land during a seizure can be incredibly difficult and therefore unsafe. Next slide, please. In terms of what you could do more epilepsy training like this, either from one of the epilepsy charities, and there are links on the last slide to some of the charities that provide training, or you could ask your local epilepsy nurse for a training session for young people that you work with. Recording seizures can be really helpful for the epilepsy team. This is because, as I said before, there are lots of conditions that mimic epileptic seizures, and there isn't a single test for epilepsy. So we make the diagnosis based on what the events look like, and it's really important that we make the correct diagnosis, as we are potentially going to put the child onto an anti-seizure medication if we think they have epilepsy. All of the medications have side effects, and therefore we don't want children on medication if they don't have epilepsy. Video footage of the event is the best way for us to make the correct diagnosis, as it really is a case of a picture paints 1,000 words. And some families will give permission for an adult or a friend to video the event using the child's young person's own phone, so it can then be sent to the epilepsy team for review. A written description can also be helpful, as long as you try and capture as much detail as possible. So things like, how long did it last? Which side of the body did it affect? What was their face doing? Were their eyes open or shut? Were their eyes staring straight ahead or to one side, or were they rolled backwards? Was there any colour change? What did the movements look like? Was there any drooling or vomiting? Was the child incontinent? Or was the child able to communicate with you during the event? The more details we have, the better able we are to create a mental picture of what that event looked like, and therefore we're more likely to make the correct diagnosis. But the other thing is, sometimes it can be really helpful to document exactly what the child or young person was doing immediately before the event. And this is because, for example, there are types of seizures called reflex anoxic seizures that are usually prompted by a small injury or a shock. So if we're hearing a history of a 5-year-old who, I don't know, walked into a door and they were fine for 30 seconds, then they lost colour, fell to the floor and had some jerking movements, which were over before a minute had lasted, and then they came round, we might be thinking, was that a reflex anoxic seizure rather than an epileptic seizure? So knowing what happened immediately before the event, details of the event, and actually also what was their recovery like? How quickly did they return to being their normal selves? And any other details in that recovery time. Did they vomit? Were they shaky? Were they a bit disorientated? That can all help create a really good mental picture for those of us who are trying to make a correct diagnosis. We've already covered the safety and reasonable adjustments. And the other thing to mention is to think about comorbidities such as autism, ADHD, and mental health conditions, because there is a really close link between all three of these and epilepsy. Next slide, please. So epilepsy specialist nurses, we have 8 acute trusts in the North East and North Cumbria, and all of those trusts have at least one paediatric epilepsy specialist nurse. We're often the first port of call for families and other professionals who need advice and support. We manage medications in clinics and over the phone. We provide training for schools, nurseries and outside agencies who provide activities for children and young people with epilepsy. And we support these organisations by writing epilepsy plans for children who have emergency medication like buccal midazolam for the treatment of seizures. Next slide, please. This is a table of our consultant epilepsy service leads and the paediatric epilepsy specialist nurses in the region. And again, this will be available to you when you are given the slide deck. But if you do need us, please do get in contact with us. We often know tips and tricks that can be helpful for those questions that might seem more complicated for you, but it won't be the first time that we've had to answer them. We can talk to you about reasonable adjustments. We can talk to you about taking people away overnight. We have a whole host of questions that we're able to answer and a wealth of information within the North East and North Cumbria amongst our nursing service. So please do get in contact with us. Next slide, please. These are the resources that I was making reference to before. Epilepsy Action, Epilepsy Society, and Young Epilepsy are 3 charities that we usually signpost people to. And, there's lots of misinformation on the internet about epilepsy, but the information on these sites is factual and updated when things change. Young Epilepsy and Epilepsy Action both offer training for teachers and other school staff, and those are free resources. And obviously, the Healthier Together website, we're working on the epilepsy resources for this website. And at the moment, there's some resources on there, and this includes recent epilepsy webinar recordings that I've delivered for schools. So please do go and have a look on there. Next slide, please. Do you have any questions for me? I'll put my camera back on.
Super, excellent. That was really, really helpful, really informative, Sophie. There's nothing in the chat in terms of questions that have been happening whilst you've been speaking. Does anybody in the room have any questions or queries that they want to raise with Sophie or Dr. Kumar, who's here in the room?
And there are no stupid questions, so anything that you do want to ask, please do.
Oh no, great, thank you. There's a comment there from Gillian just to say that it was very informative.
Oh, you're welcome.
Is there anything you would like to add, Dr. Kumar?
Oh, Dr. Kumar, you're on mute.
So it was wonderful talk. I think probably sometime if the presentation is so clear, people may not have any questions to ask. However, it's important that you have given a key message that epilepsy is common. It is common in children. The children are in the community, at home, or in the school, or in any other areas. And they need attention if they're having seizures. You have gone through different type of seizures and what can be done to support the children in the management and also in other areas of comorbidity. So from my point of view, wonderful talk. And people may not have any question now, but if they have any question in the future, I'm sure Luz will and you will mention about your contact details and people can come back to us. So, but wonderful talk and thank you from my side.
Thank you.
Great, thank you very much. So if there aren't any questions, then we'll just sort of round up. We at the moment don't have a slide with our contact details, but we will add that to the slide deck before we circulate it. So apologies about that. But yes, more than happy to answer any questions. Obviously, Sophie and Dr. Kumar from a clinical perspective and myself from a programme management perspective around epilepsy and long-term conditions. I wonder if we could just have the slides back just so I can do the last couple of roundup slides. So just for information then, in terms of Healthier Together more generally, we're really grateful for people's participation today and just wanted to highlight some of the most recently added pages and items within Healthier Together. All of these are acts as links. Oh, here we are. There's actually an epilepsy related question here within the chat. That's great. Thank you. Sharon, is there an issue with children and young people with epilepsy using stair lifts or through floor lifts?
No, is the short answer, but the longer answer is this has been raised with me before because I think it tends to be children who have additional needs, and therefore there's a concern that they might fall from the the lift. I would, if that's the only way that a child can access their own bedroom or the rest of the house, then they need to use them. Obviously with appropriate supervision. And the other thing to say is that if someone is in a chairlift or they're in a wheelchair, when they're in the lift, if they were to have a seizure, there is actually specific advice available on the Epilepsy Action website on how to manage a seizure with a child or young person in a wheelchair. And I'll just really, really briefly go through it. If they are secure, you're going to leave them secured into their either the wheelchair or to the seat that they're in, because they're not going to go anywhere if they've got a harness on. You're going to gently support underneath their chin so that their chin doesn't drop to their chest, because as I said before, chins on chest, even if you try it for yourself, it's not the best position to breathe in, because most seizures are very brief and the 90% of them have stopped within 5 minutes, which can still seem like a long time. You're just going to support them. You would obviously stop the chairlift. And then if the seizure was going on for longer than 5 minutes and you felt that you needed to move them, you could then move them onto the floor. Okay, but you can give rescue medication, emergency medication while someone is seated. Dr.
Okay,
Kumar?
thanks. Yep, Dr. Kumar, yep.
The other thing which is important, as Sophie mentioned, that lift are usually for children with the complex medical needs, and probably those children already had assessment by occupational health team, and probably there are appropriate adjustment has been done in the house. Most of the time, I think the children usually stay on the ground floor, so use of lift is very, very small. But obviously, so just going through their occupational health report and adjustment would be useful.
So just to extend that conversation, we've had a further follow-up comment to say, is the use of the stair lift with the risks you've explained preferable to sleeping on a different floor to their parents? So for example, if the parents were to be sleeping upstairs and the child sleeping downstairs.
Again, it's going to be really individual because we're talking about a whole spectrum of children and young people, some of whom epilepsy is their only medical condition, and right through to children who have incredibly complex needs, and epilepsy is part of their underlying condition. I guess it raises the issue of overnight monitoring. That's kind of inferred in that question. There are different types of monitors out there for epilepsy, but what I would say is that if the NHS doesn't fund them, they are usually in the region of £500, and there hasn't been any research that conclusively has concluded that an epilepsy alarm will prevent a child or young person dying, which is what everybody worries about, I guess. So, and again, it's going to depend on the type of seizure. Some children are incredibly noisy during their seizures. They make banging noises. They make a kind of during tonic-clonic seizures, again, which you can hear throughout the house. Whereas other people, they might have stiff seizures and they don't breathe particularly well and they're incredibly silent. So it really needs to be assessed on a case-by-case basis. And again, for children with very complex needs, they probably have occupational therapy involved and an epilepsy nurse who can contribute to that conversation. But for all children and young people with epilepsy, that is probably a conversation that you want to get their consultant and their epilepsy nurse involved in, so you can think about what their seizures look like, how likely a parent is to be alerted, and what the risk is of a seizure overnight.
Thanks, Sophie. That was a really helpful, comprehensive response. So hopefully that responds to that query. Now, is there anything else? Is there anything else anybody wants to bring to the fore, or raise their hand, or put something in the chat? Give people a minute or so. Okay. All it looks to be all quiet on the Western Front. Carol, could we have the slides back, please? Thank you. Great. So in terms of just a roundup, just sort of to follow on from obviously the conversations around epilepsy, there's a whole host of information on Healthier Together, obviously wider than epilepsy. And this is a list here of just sort of some of the most recent pages that have been added to Healthier Together in terms of content. So if I could ask for the next slide, please. As mentioned, we have an ongoing programme of communications and engagement, and obviously part of that has been a range of a series of Healthier Together lunch and learn sessions. Obviously, this is one of them. We've done ones previously, and we've got future ones planned, which we usually communicate and advertise through our Child's Health Tuesday news bulletin, and obviously through direct communication with our VCSE Healthier Together champions and others. So please do let us know in the chat if there's anything additional that you think you might like information on, and we'll seek to be able to ready a session for you. And then just to the last slide. And that's just really to say thank you very much for coming. Please do stay in touch. There's a whole number of mechanisms there for you to be able to leave us some feedback or engage with us more generally as part of the network. And we're very, very grateful for your time today, and I hope it's been a useful session. Have a lovely weekend, and thank you very much, everybody.